So our next speaker is Dr. Ronald Hoffman. Dr. Hoffman, there he is, from Mount Sinai Hospital, is going to talk about some basic aspects of myelofibrosis and how it may affect management.
Thanks, Dick. It's always a pleasure to come to this audience and go over where we are. So what I'm going to try and tell you is what we do at Mount Sinai, and that could be overlap with what your own doctor does or what you read in the literature, but it's really sort of a personalized approach of what we do with our patients. So here's my conflict. So I have some companies that give us money for research. And I think the important thing to recognize here is here's the expected survival of patients, of individuals that are normal, don't have myeloproliferative disorders. And here you can see the survival of patients with myelofibrosis, polycythemia vera, and essential thrombocythemia. And you can see that the median survival of patients with MF is about 10.8 years. And it's far inferior to those patients who have polycythemia vera. And also, I'm sorry, I have it backwards. Here's the patients with myelofibrosis. The median survival is 5.8 years. So myelofibrosis is really a disease that has the diagnosis has a much larger impact than polycythemia vera and essential thrombocythemia. It's a more advanced form of this disease. The patients are usually symptomatic, and they have low blood counts. So it's also a heterogeneous disorder. So there are patients who are diagnosed at early phases of their disease who can live long periods of time, and then there are individuals who are diagnosed at late onset disease who have a very rapid downhill course. So because of this heterogeneous disorder, you can see on the left here, there are individuals who present with an early form of myelofibrosis. And those are the patients that Dr. Silver and Dr. Hasselbach were frequently talking about with these interferon trials. These are patients who are relatively asymptomatic. They probably have some systemic symptoms, and they have near normal blood counts, except for frequently they have elevated platelet counts and mild anemia, and they can have asymptomatic splenomegaly. Unfortunately, this is a disease that is a progressive disease, and patients then evolve to more overt forms of myelofibrosis. In addition, patients with essential thrombocythemia and polycythemia vera can also evolve to more overt forms of myelofibrosis. And this more progressive or more advanced form of the disease is associated with progressive cytopenias, constitutional symptoms, and progressive splenomegaly due to blood cell production leaving the marrow and residing in extramedullary sites such as the spleen. And as been well shown by many of our colleagues, this progressive form or overt form of myelofibrosis is associated with a decreased quality of life and a progressive incapacitation and immobility. Eventually, about 20% of these patients go on to develop what we call MPN blast phase. And that's a syndrome that resembles acute myeloid leukemia, but it's a form of secondary acute myeloid leukemia that we are very bad, unfortunately, at treating. So we don't have great drugs to treat MPN blast phase. So our therapeutic strategy is really to try and intervene and to hopefully our therapeutic and prevent patients from developing MPN blast phase. So if you have myelofibrosis, just trying to look at what the problems are, we can learn something from looking at the causes of death of patients who have myelofibrosis. And you can see that over 50%, almost 50% of the patients die of either leukemia or progression without developing leukemia. You can see, like the other myeloproliferative disorders, that these patients are at an increased risk of developing clots, infections, and sometimes patients bleed either due to qualitative functional abnormalities or their platelets, or due to esophageal varices as a consequence of their large spleens. And unfortunately, some of these patients die of other malignancies. So, Andy made a big point about talking about these prognostic scoring systems. And bottom line for us, these prognostic scoring systems are important for essentially defining the therapeutic strategy that we're going to take for treating patients with myelofibrosis, whether we're going to observe them, whether we're going to treat them with drugs, or whether we're going to send them to transplant. And a lot of information is essentially gained by looking at their mutational status, their driver mutational status. And that includes the calreticulin mutation, the JAK2 mutation, or a mutation in the thrombopoietin receptor, which is called MPL. And then there's a subpopulation of patients who don't have one of these driver mutations, and the aficionados in this group essentially call that triple negative disease. And as you can see, those patients who lack a driver mutation, they have an extremely short median overall survival, while those patients who have JAK2 or MPL mutations have an overall survival of about 9 years, and those patients who have a calreticulin mutated disease have a median overall survival of 17.7 years. So your driver mutation is going to tell us something about the biology of the disease, and that's how you should really think of it. It's not like we're going to be able to specifically target this right now, but what we're trying to learn is how much risk we should put you at from a particular therapeutic intervention based upon your prognosis. So the prognostic scoring system that we use is this Molecular International Prognostic Scoring System. And I don't want to bore you with a gazillion prognostic scoring systems, but the utility of these scoring systems is essentially so that we would be able to define who should go to transplant, who should be treated with drugs, who should get palliative therapy, and who shouldn't be treated at all. So these are the variables: age greater than 60, hemoglobin less than 10, constitutional symptoms, platelet count less than 200,000, not having a driver mutation, which we'll call triple negativity, having a JAK2 or MPL mutation, as I showed you, that's really not a great thing, and then having these additional mutations, such as AS6L1 and SRSF2. Now, if you have a driver mutation and then you have these additional mutations, you can see the more mutations you have, these are mutations in genes that are associated with myeloid malignancies, you can see that the overall survival decreases dramatically if you have multiple mutations beyond your driver mutation, and that confers an inferior prognosis. So right now, the state-of-the-art of treating patients with myelofibrosis is essentially pretty primitive when you really think about it. We just don't have the drugs available to us to essentially target the cancer stem cell. We have drugs that are in development, but when you're basically here in October of 2019, these are the agents that we have. So we can treat patients with anemia, with erythropoietin or darbepoetin, androgens, corticosteroids, and then immune modulatory drugs such as thalidomide or lenalidomide. We don't empirically treat patients with asymptomatic splenomegaly, but those patients who have large spleens, we treat them with ruxolitinib or with the newly approved JAK2 inhibitor termed fedratinib. I apologize. And in rare instances where those drugs are not effective, we treat patients to palliate them with removal of the spleen. For constitutional symptoms, which is a real big deal in this disease, we almost uniformly treat patients with JAK2 or JAK1 inhibitors. In addition, for extramedullary hematopoiesis, beyond the spleen, we use those two agents, and rarely we use radiation therapy. In the early phases of the disease, if the patients have had a thrombotic episode, we use either hydroxyurea or interferon, and we frequently treat patients with low-dose aspirin. The only modality of therapy that we currently have that can cure patients with allogeneic stem cell transplantation, can cure patients with myelofibrosis is allogeneic stem cell transplantation. So one of the big advances, I think, is the greater utility of allogeneic stem cell transplantation with reduced intensity conditioning for appropriate patients who have a good performance status with advanced forms of myelofibrosis. And this is a study that we did in our consortium. And you can see that patients who have a matched sibling donor, that they have essentially a 70% chance of cure. While those patients who have a matched unrelated donor, that their chances of cure with allogeneic stem cell transplantation is about 30 to 35%. This is a paper that really fascinated me, and I thought I would share it with you. It's a paper from Dr. Bacigalupo, who is in Rome right now. And essentially what it showed is the survival of patients from the years 2000 to 2010 with HLI identical sibling transplants or alternative donor transplants. And it shows that the survival data is far less than what I've previously reported, and that the improved survival, if you have a matched sibling donor, is likely due to the improved supportive care that we can provide to patients undergoing transplant. The most important part of this figure is basically here. Here, Bacigalupo in his clinic, then at Genoa, showed that that transplants recipients who received what's called a haplo-identical transplant, that's from one of their siblings or one of their kids, using a type of conditioning regimen and post-transplant immunosuppressive therapy, can have an identical transplant outcome as those patients who have an HLA identical sibling donor. And that to us is really a game changer. This kind of post-transplant immunosuppressive therapy was developed at Johns Hopkins and also in Perugia in Italy. And at least at our institution, our overall strategy is to try and transplant or urge patients, if they agree to it, to go to transplant if they have an appropriate donor. And that includes an HLA matched sibling donor, a donor who's very closely matched who we can get from the National Marrow Donor Registry program, and now haploidentical transplants. So that includes patients, children, or their siblings. And that's really expanded the number of transplants that we can do. And our haplo program at Sinai, as this occurs at Hopkins, really has some very promising results. So this is a drug that you guys call it JAKARTA. We call it ruxolitinib. We can call it whatever we want to call it. This drug's sort of a game changer for those patients that are not transplant candidates. And my colleague, Dr. Berstovsek, shows a very impressive slide of somebody who goes from the horizontal to the vertical with the administration of this drug. So I think this drug is a very, very good drug. Here you can see that if you get this drug the vertical axis is the size of the spleen, you can see that there's a dramatic reduction in the spleen in many of the patients who get ruxolitinib. And most important, at least to us, is the total symptom score, how the patients feel, because many of the patients with myelofibrosis really have a dramatic reduction in their quality of life. And the green figure line basically shows the improvement of symptom score. And I think for these patients, this drug is really a lifeline and really improves their quality of life and allows them to function. And there's some suggestion based upon data that's been culled together from several institutions and cooperative groups performed by these pharma-sponsored trials, that there might be a modest prolongation in survival in those patients with advanced forms of myelofibrosis who get ruxolitinib therapy. But this is an area of great controversy. Now, what about survival by mutational status when you get ruxolitinib? And here you can see on the left, you can see that if you don't have one of these other myeloid mutations, you only have your driver mutation, you can see in the blue that you do much better. So what this tells you is that essentially the outcome is going to be dictated by your mutational status, or at least we're going to get more improvement from that or information from that. And furthermore, you can see that here that the survival of those patients treated with ruxolitinib who have greater than 3 mutations is far inferior than those patients who have a lower mutational burden. So this will just give you an idea of what you can expect with this particular form of therapy. Now, I'd express some caution about the interpretation of looking at these figures that we play around with, because you are an individual, and these graphs show the larger patient population. So I don't want you to, essentially panic about these kinds of data, but I think it's important that you're aware of it. Now, the biggest problem we have with ruxolitinib or Jakafi is that many of the patients develop anemia. And this is a study that used basically darbepoetin or erythropoietin to treat patients with anemia that developed while the patients were receiving ruxolitinib. And you can see this is a single-arm study. You can see that 55% of these patients responded, and the time to anemia response was about 4 months. And this is a study done from very good investigators in Spain. And here you can see that in many of these patients, on the top, you can see that the duration of anemia response was really pretty excellent if you were able to get a response with this erythropoietin stimulating agent. And the nice part of it is you could continue your ruxolitinib and essentially get the benefits of that kind of therapy. The problem with ruxolitinib is shown here. This is a paper that was published by Serge. And you can see over time, at 1 year, 21% of the patients had to discontinue the therapy. By year 2, 35% of the patients had to discontinue therapy. And by year 3, 51% of patients had to discontinue therapy with Jakafi or ruxolitinib. Why did they discontinue therapy? Because essentially they develop low blood counts, or they lose their response, or their disease progresses. And that sort of indicates that this drug, although it's a fantastic drug, it doesn't really prevent progression of the disease, and it is associated with some side effects. And if your ruxolitinib has to be discontinued, the median overall survival is approximately 14 months. So what it really is it's a study that shows that if you cannot tolerate ruxolitinib, or if you have progressive disease, that's a warning sign that things aren't going to go very well, and you should really start considering alternative options, either stem cell transplantation or clinical trials. This is an interesting study that was published from the Moffitt Cancer Center of patients who were receiving ruxolitinib. And you can see that of the 148 patients, 23 patients died while taking ruxolitinib. 58, or a minority of the patients, remained on ruxolitinib, and 64% of the patients had to discontinue ruxolitinib. So this is a real-life study. And how good are we at essentially improving outcomes with the salvage therapy that was available at that time? Basically, there was minimal effects on salvage therapy. And in this figure, it shows that you can see in the green, you can see those patients that got transplanted had a far better outcome than those patients who were treated with drug therapy when they had to discontinue their ruxolitinib. Our big problem with ruxolitinib is essentially identified by this patient who developed a rash. She had a fantastic response to this drug, but she developed this rash, which was biopsied and found to be MPN blast phase. So we are very wary of essentially over-treating patients with this drug because of our experience of evolution of the disease, even though the inflammation is being controlled. So in August of 16th, 2019, a new drug came to the market. It was approved by the FDA. It's another JAK1, JAK2 inhibitor. It's called fedratinib. And this is the first new treatment in nearly a decade for patients with myelofibrosis. So the approval was kind of remarkable because this drug is kicked around for a long period of time. As many of you realize, it's been called by many different names. But the first trial was essentially done by Aminesh Pardhanani, who's at Mayo Rochester, many years ago. This was in 2013, published in 2013. It's basically primary MF, post-ET-MF, and post-PV-MF. And people got this drug daily. It's an oral drug. And if you didn't respond or you got the placebo, essentially you could cross over to get the drug. The primary endpoints of this study were the spleen reduction, and then the secondary endpoint was essentially symptom response. So looking at this, you can see when you compare the placebo to the drug, you can see that that essentially very few of the patients had a reduction in splenomegaly with placebo, but the drug actually reduced the spleen size in about 20 to 30% of the patients. So there's another trial which is a little bit more relevant to what we're interested in is basically in those patients who are intolerant or resistant to ruxolitinib. This is the so-called JAKARTA 2 trial. Patients were started on 400 milligrams for 4 weeks. The permitted dose adjustment was 200 to 600 milligrams. You could be dose up titrated or down titrated. And they looked at symptom response and also splenomegaly. So you can see that the response rate in this second-line myelofibrosis patients was that about 50% of the patients did quite well and had reduction of their spleen size, and actually about a quarter of them had a reduction in their symptoms. So that's very impressive. So here's the summary data. The nice part about this drug is it would appear that it is less effective in inducing thrombocytopenia, low platelet counts, and perhaps also can spare the anemia that is such a big problem. So it's important for you to realize that there's a black box warning for this drug because during the development of the clinical trial, during the pursuit of the clinical trial, several patients developed what's called Wernicke's encephalopathy. And that's a serious neurologic disorder that's reported in 1.3% of the patients taking this drug. And there's been a lot of discussion of whether this is due to the drug or not. But the label of this drug suggests that your doctor check your vitamin B1 level, and if it's low, that you have supplemented with thiamine or vitamin B1. So just so you're aware of this, if you get on this drug, you should help your doctor out. Wernicke's encephalopathy is characterized by profound disorientation, indifference, and inattentiveness, ocular motor dysfunction, and also gait ataxia. So you're basically not yourself, and it's a progressive problem. It's reversible if you go off the drug, and it's also reversible if your thiamine levels are replenished. So that's really very important. So what happens if your disease progresses to leukemia? We divide these leukemic phases into accelerated phase. That's if you have 10 to 19% of blasts or leukemia cells in your peripheral blood, or outright blast phase when you have greater than 20% blasts in the peripheral blood. This type of leukemia, we are not good at treating. We don't have effective drugs. So we've tried to put together regimens that can prolong survival and perhaps bridge patients to transplantation. And when I say transplant, I mean we're transplanting now patients up to 70 years of age. So, we're trying to do the best we can with patients that that we believe have a curative disease. This is a tough nut to crack. So in our consortium, we've done a combination therapy trial. We had previously reported that a hypomethylating agent called decitabine, at least at our single institution, led to remarkable responses in MPN blast phase in a subset of patients. So of course, doesn't take rocket scientists to figure this out. We combined this drug with Jakafi or Ruxolitinib because we thought that this drug would be effective. So in this phase 2 trial that was performed at multiple institutions here in the United States, you can see the doses of Ruxolitinib. Overall, there were 21 patients treated. In the phase 2 trial that hasn't been reported yet, there were additional 19 patients treated. You can see that eventually many of these patients succumbed to their disease, even in the face of this kind of therapy. But you can see that the overall survival of these patients on the left was prolonged to about 10.4 months because prior, Ruben Mesa and his group had shown that these patients really have an overall survival that's less than 3 to 6 months. So this is a minor victory. It's not a major thing, but it essentially gives us hope that we can then go on to try and transplant some of these patients that we can get back into the chronic phase of the disease. And this is a study from France, and it is basically the results of allo stem cell transplantation of patients with MPN blast phase. And the top line is those patients that received the allo transplant, and the bottom line is those patients that didn't get a transplant because they didn't have a donor or they were too sick. And as you can see, the patients with transplant essentially did better, and virtually all of the patients, unfortunately, who didn't get a transplant succumbed to their disease. So we've tried to essentially, I'm sorry this slide didn't come out, we tried to essentially recapitulate this at Sinai, and I can tell you that the 2-year overall survival in about 11 patients who we put back into remission with MPN blast phase. And remission, I mean the chronic form of myelofibrosis, that 40% of them are long-term survivors at 2 years. So when I look at this and really honestly try and tell you what I think there are limited therapeutic options for patients who do not respond to frontline therapy for myelofibrosis. Ruxolitinib and fedratinib therapy should reserve for patients with disabling systemic symptoms and/or symptomatic splenomegaly. We do not empirically treat everybody with Jakafi because there are side effects of Jakafi, which I didn't go over. In medically fit patients with advanced forms of myelofibrosis who have an appropriate donor and are in good shape, we strongly recommend allogeneic stem cell transplantation after spending a lot of time talking to the patients about the risk and the benefit of allogeneic stem cell transplantation. Ruxolitinib is not complication-free. It's an immunosuppressive agent. So there are some infectious complications that have been reported. There's some debate about that. Also, more aggressive forms of skin cancer and lymphoma have also been suggested. And with Wernicke's encephalopathy, with fedratinib, essentially, Wernicke's encephalopathy is a real concern, as is the patients frequently have severe diarrhea. And if you do not respond to the standard of care, I would encourage you to either go for a transplant or to participate in a clinical trial if there's a site available to you, because that's the only way we're going to make progress in this particular field. We are desperate to make advances. We have loads of drugs that are in clinical trials at our institution and at multiple institutions throughout the world. And some of these drugs are working, and you'll hear about that at the ASH meeting in Orlando. Most importantly, make sure you read the consent form. This is an experimental trial. You are part of an experiment. So if the doctor sort of glibly says, oh, it's going to help you, I would take a step back and go home. We usually send the consent forms home with the patients, refuse to allow them to participate in a clinical trial unless they come back in a week and have gone over it with themselves and their relatives. So I mean, just don't sign on to anything and go into this with your eyes open. This is from somebody who is really into drug development, so I hope you appreciate that. And here's our group at Sinai. We have tremendous people. John Mascarenas is the leader of our clinical program, and he does a really superb job. So thank you for this opportunity, and I hope you found this useful.
Thank you for that great talk. We have time for one question, if any, from our co-professors. Any comments? Serge, Hans? Yes.
Thank you very much for a nice, comprehensive presentation. Have you any comments on the association between Ruxo and malignant lymphoma? As far as I can see, it is 1-1 now.
Yeah, so we went back and we have.
Would you repeat the question?
So the question is there's a type of aggressive B-cell lymphoma that's associated with upregulation of the cancer-causing gene MYC. And we've gone back and looked. We have hundreds of patients that have been treated with Jakafi or Ruxolitinib. We did find some patients who developed lymphoma, but also we have patients who have coexisting lymphoproliferative disorders and myeloproliferative disorders, which for us is an increasing problem. So we were unable to essentially identify this population that was previously noted from the Austrian group in our patient population.
Thank you. And if that person says, I'm from the Internal Revenue Service, I'm here to help you, that's another reason to not come back, right?
Right.
Right.
Thank you, Dave.
Thanks very much, Ron.